Right, good afternoon and welcome to the second of the MASD Awareness Day webinars supported by the Harm Free Care Network and Medline. This session is being recorded. We're delighted to have Professor David Voegeli as our speaker today. David is a Professor of Nursing with the Faculty of Health and Wellbeing at Winchester University and has an international reputation in the field of skin health and tissue viability. Much of his recent research has focused on moisture-associated skin damage in both clinical and laboratory settings. David has published extensively in the areas of skin health and clinical nursing, with over 150 papers, book chapters, and scientific abstracts published with leading international journals. Today, David is going to talk to us about the prevention and management of intertriginous dermatitis, a condition that up to 1.2 million people in the UK are susceptible to. Everyone will be on mute throughout the session, so please put your questions into the Q&A panel at the top of your screen and as we go, and then we'll try and answer those at the end. Okay, David.
Okay,
Let me just put your video on the screen. There we go. There.
Okay. Thanks, Simon, for that introduction, and it's a pleasure to be here and talk about, say, one of my research interests, so moisture-associated skin damage. So most of you will be aware that moisture-associated skin damage is an umbrella term and consists of four distinct forms of skin damage. So incontinence-associated dermatitis, peristomal dermatitis surrounding stomas, and peri-wound dermatitis due to excessive exudate. Now, obviously, what we're going to be focusing on in this webinar is the other form, and that's intertrigo or intertriginous dermatitis. I'll probably keep referring to it as intertrigo just because it's easier to say. So that's what we'll be focusing on today. So what is intertriginous dermatitis or intertrigo? It's basically an inflammatory skin condition that develops in opposing skin surfaces. So it occurs anywhere where we have skin folds and where there are two skin surfaces that come into contact with each other. And it occurs in response to friction, humidity, and reduced air circulation. And the diagrams or the pictures on the right hand side show you the different forms. So hopefully you can see my cursor, and this is showing intertrigo under the breasts. And you can see quite nicely the sort of inflamed areas. Also occurs within the digits, so obviously toes and hands. It can occur under the sort of apron that obese individuals get, and is actually very common in children, particularly babies, due to their very short necks and skin folds around the neck. So the classic signs of intertrigo are this mirror image erythema or redness in the skin folds, and that can progress to erosion, oozing, exudation, maceration, and obviously secondary infection. So how common is it? Well, Simon mentioned about 1.2 million people in the UK potential risk. Unfortunately, we still don't have accurate incidence and prevalence data for intertrigo, and certainly in the UK, although hopefully that's getting better now our reporting mechanisms are certainly improving. What we do know from the literature, though, is in the USA, who tend to lead the field in studying this form of moisture-associated skin damage, about 2.6 to 40% of the population suffer from intertrigo. That's highly linked to areas where there's a high instance of obesity, and obviously the USA is one of the areas that leads the way in that, unfortunately. and obviously we're catching up. In Europe, a more recent study by Kottner et al, where they actually looked at secondary data analysis of 4 annual multi-centre prevalence studies from the Netherlands, showed prevalences of 2, 7 and 10% respectively. And that, so incidence actually increasing from acute care through to care homes and home care. So what does that actually tell us? Well, it suggests then that there's a strong association between the presence of intertrigo and the degree of dependency on care staff to maintain hygiene needs. So firmly suggests we need to have a good understanding, and we need to be on the ball really to pick this up and hopefully be able to advise patients accordingly. So the common locations, I've talked about some of these and shown some of the pictures. The diagram illustrates again the common areas where intertrigo can occur. I've talked about babies, so particularly around the neck with their sort of constant drooling, which then can get trapped within the neck folds and very rapidly lead to intertrigo. Under the breasts in women, again, another common area. The axillas in individuals who are obese, so typically the bariatric patient, we often see it in the back, in the abdomen, so anywhere where there's again a large skin fold. And this also occurs in bariatric patients, can occur in the upper legs and behind the knees. So what that suggests then is that anybody, certainly any bariatric patient, we need to be particularly careful in ensuring we do assess and inspect their skin folds. We know the risk factors for intertrigo, again, heavily linked to increases in body mass index, but other risk factors then hyperhidrosis, in other words, excessive sweating, obviously individuals with compromised mobility who are generally increased risk of moisture associated skin damage anyway, inability to perform personal hygiene. There is a strong link with diabetes mellitus and obviously hot and humid environments, which obviously means at the moment in the UK we don't really have to worry about that. So thinking about the mechanisms and what's actually going on that actually causes the skin damage. And this is a particular area of interest of mine. So this diagram just summarises some of the mechanisms that work together to actually cause intertrigo. So we start off with obviously excessive moisture. Now obviously in the case of intertrigo, that's generally sweat. Obviously in the case of babies, it's excessive saliva. It can be urine, so we can get a sort of mixed picture, particularly in patients with incontinence associated dermatitis. So there can be a mixed picture there, which just adds to the confusion. And then put into the mix inadequate drying or actually getting rid of the moisture. So the excessive moisture then collects in the skin folds. We've talked about where they might be found in the body, and that leads to two factors really. The first is that excessive moisture actually causes overhydration of the uppermost layer of the skin, the stratum corneum, and if you remember, that's the actual layer that forms the barrier for the skin. So that becomes overhydrated, starts breaking down. At the same time, wet skin, we know, has a higher skin friction coefficient. What does that mean in practice? It means the skin becomes sticky. It sticks to bedclothes, it sticks to clothing, and it certainly sticks to other skin in those skin folds. So all in all then, that leads to breakdown of the stratum corneum, increased friction, which means the stratum corneum starts being stripped off. So we start losing that important protective skin barrier. At the same time, the stratum corneum is trying to repair itself, but the overhydration leads to an increase in pH, So a familiar pattern actually we see in other forms of moisture-associated skin damage. So a move in pH away from that protective acid mantle that we all talk about. So what does that actually do? Well, it changes the structure of the stratum corneum. So the actual intracellular lipids and the cells themselves, the corneocytes, start becoming disrupted, and then with that increased friction, start being stripped away. So the end result then is we see an increase in skin permeability. So we've totally lost that barrier function. That promotes the proliferation of any microbes that might be around. And obviously, as you know, the skin is full of bacteria, normally not causing any problem. But obviously in these conditions, they start to proliferate, can actually start to get into the skin, and obviously that starts an inflammatory response. And then we see that clinically as the erythema, the redness in intertrigo. So understanding these mechanisms helps us understand some of the interventions that might work in preventing this, or some of the interventions that we can use to actually manage it if it's actually occurred. Now, I talked about how very often we end up with some secondary infection due to bacteria, fungi, etc., that might actually be on the skin anyway. So normally, as I've said, they don't cause any problems, but with that breakdown in skin barrier, they can actually gain ground and cause troublesome infection. So the classic top picture shows inframammary intertrigo, so obviously under a lady's breasts, and you can see that again, that classic mirror image erythema, so where it sort of mirrors where the skins come into contact with each other, and this shows quite clearly the classic satellite lesions, so this sort of spotty appearance, which is classic of Candida infections and the fungal infection. And this is probably one of the most commonest, actually, if not the commonest, secondary infection that complicates intertrigo. The second one a bit more serious, but hopefully the picture sort of gives the game away, just in case you can't quite work out what it's showing. This is actually the back of the neck of a young infant. Not quite sure about the colour of the fingers actually holding the skin apart, but we'll worry about that another time. But you can see quite clearly that real fiery red inflammation, classic of a streptococcal infection, and just the sheer sort of ferocity of that hopefully would lead you to seek advice, and obviously those situations require antibiotics fairly quickly. And then one that is often people often put up with actually is the brown discoloration that you may have seen again in skin folds, typically under the axillae, or actually in the groin is another common area where you see erythrasma, and that's a brown skin discoloration that occurs due to a specific bacteria, Corynebacterium. This can actually, Corynebacterium and erythrasma, I have known actually to be the first sign of a patient with undiagnosed diabetes, particularly type 2 diabetes. And again, there's that real link between intertrigo and diabetes. So hopefully you've seen then that classic assessment and identification of intertrigo is normally fairly straightforward. It's given the history of skin folds, excessive moisture, any of the other risk factors, normally you can safely say it's intertrigo. But what else could it be? There are a few other skin conditions that can mimic intertrigo, or intertrigo can mimic these skin conditions. But as a general rule of thumb, these are a bit rarer. And generally, if your initial suspicion of intertrigo, if that's not responding to standard interventions, then normally most people would seek specialist advice. But other things it could be, obviously there are some types of psoriasis, inverse psoriasis, which can occur in certain areas that intertrigo can occur in. There's the rare Hailey-Hailey disease, which is a genetic disorder, so on and so forth, right the way through to some drug-related skin reactions. But as I say, normally, if initial treatment is not working, then you would seek advice and hopefully specialist advice. So thinking about the mechanisms, thinking about how potentially it should be reasonably easy to assess and identify intertrigo, why do we need to think differently about it? Well, the fact of the matter is we still don't always know it when we see it. So there are still assessment challenges, and it's still often not picked up or not identified quickly enough. We don't always know what to do about it, and that's one of the major problems. So even when we do pick it up, very often we don't know how to actually manage it. And we still see issues with many ineffective treatments continuing to be promoted. And at the end of the day, there's a lack of high quality evidence. And by high quality evidence, what I mean are things like good, robust, randomized controlled trials. So we've got plenty of case studies, we've got plenty of anecdotal reports, but what we really need to actually confirm effectiveness of interventions is that high quality evidence that we can use. Now, I mentioned some sort of ineffective, unproven treatments that continue to be promoted, and even, now we still see ineffective treatments, particularly being proposed on the internet. So people seeking self-care advice will often find some quite dubious claims, and even on sites aimed at healthcare professionals still promote some of these practices that actually have no basis and can actually cause more harm. So things like the use of talc, cornstarch powder to try and mop up the excessive moisture. The problem with that is obviously, yes, that initially mops up moisture, but then it becomes caked and basically provides a breeding ground for bacteria. So it can actually make the matter worse, leads to inadequate cleaning, bacterial growth, and so should actually be avoided. Some people recommend applying antiperspirants under skin folds. Obviously, if intertrigo's there, that will sting like nobody's business, and again, often doesn't work, and again can actually leave the skin wet, increase the friction and increase the damage. Then some of the weird and wonderfuls. So some people recommend vinegar soaks, so soaking gauze in vinegar and keeping that under the skin folds. Again, most patients won't thank you for that, particularly if they've got a rip-roaring inflammatory intertrigo, because again, that will sting. Wet tea bags. The rationale for that is the tannin in the tea is supposed to be an astringent and hopefully try and keep things dry. But I think wet tea bags are probably best placed in the bin, not in the skin folds of patients with intertrigo. And then probably one of the most common things that people do, because they simply just don't know what else to do, and lots of patients will do this themselves, and that's sort of stuff, gauze, cotton wool, paper towels, bits of material, whatever they can find in the skin folds, in the hope that that will actually mop up any excess fluid. Obviously that's going to mop up some, but then it becomes very quickly soaked, saturated, and there's nowhere for that excess moisture to go. So it just, in the end, acts as a reservoir, actually holds it to the skin in the skin folds, and actually makes matters worse. Plus, again, it increases the risk of secondary infection. Now, in 2018, the Journal of Clinical Nursing actually undertook an online survey just to find out what nurses, particularly in primary and community care, were actually doing to manage intertrigo. And reassuringly, when we think about some of those ineffective treatments, the highest proportion here, shown in blue, was actually using an antifungal cream, which actually is good, obviously recommended. And actually most of the sort of potentially damaging interventions were fairly low. But even still, we still see people were using talc, small percentage. Some were using steroids. That's fine. That will, yes, certainly dampen down the inflammation. But remember, a steroid cream on its own will not treat any secondary infection and can actually make matters worse. So yes, you can get combined steroid and antifungal creams. That would be okay. But if you're using a single cream, rather an antifungal than a steroid. Worryingly, some people are still using moisturizers. Now, the whole sort of concept of moisture-associated skin damage, i.e. excessive moisture is causing a problem, you don't want to add to that excessive moisture by moisturizing. So there's a time and place for moisturizers, certainly not in the treatment or management of intertrigo. And then barrier creams, barrier products, again, yeah, to help prevent it, but again, has to be used at the right time. If there's infection, you certainly shouldn't be using a barrier product until that infection's been cleared, because otherwise you'll just trap it in there. So leads quite nicely on to evidence-based care. Now, I've mentioned that unfortunately there's limited high quality evidence, and I've explained what I mean by high quality evidence. But what we do have is quite a good body of consensus clinical opinion. So initially, there's been sort of clinical consensus since 2013, and more recently this was updated in 2020. So there's 4 primary interventions really for the management of moisture-associated skin damage of any cause. The first is obviously to minimise skin-on-skin contact and friction. 2 is the adoption of a structured skincare regime. 3, obviously the use of products that wick moisture away from at-risk skin or protect the skin. 2 3s. Control the cause of the excessive moisture and prevent and treat any secondary infection. So relating that obviously primarily to intertrigo, well, obviously minimise skin-on-skin contact and friction is of vital importance. Not that easy to do. Sounds easy in principle, but not that easy to do in practice, although we have got some developments now that certainly play a major role in that. Obviously using products that wick moisture away from the skin and protect the skin. So if there's no infection, if there's the intertrigo has sort of on its way out and you want to prevent it coming back, that's really when barrier products play a role, and certainly some of the film sort of spray type or liquid type barrier products can play a role there. And then obviously preventing and treating any secondary infection. The intertrigo is not going to heal, it's not going to be managed unless you treat that infection and typically that will be where antifungals come in. So thinking about the best practice recommendations then, how are we going to prevent and manage intertrigo? Obviously, we need to emphasize the importance of maintaining hygiene and certainly educate patients in the care of skin folds. Obviously, we need to ensure that patients know how to keep the skin areas at risk clean and dry. If they're reliant on care, then we need to obviously know how to do that, and we certainly need to ensure that all skin folds are inspected regularly. I've mentioned about the danger of applying skincare products before we've dealt with any infection, and that's vitally important. So before applying any skincare products, rule out infection, because nothing will work until that infection has been dealt with. And then consider the use of moisture wicking textiles. So this is where there's been a huge advance. Although moisture wicking textiles aren't new, they've certainly been around, well, they're new to the UK, but they've certainly been around in the States for probably about 20 years now. And these are specially woven fabric that's actually designed to be placed within the skin folds, and then some of the fabric actually left hanging out, and that's quite important. And what that does is the fabric's designed to actually provide a wick, so the moisture, excessive moisture in the skin folds is taken out and then can actually evaporate to atmospheric air. So it actually keeps the skin folds clean, dry, and also prevents the friction. The other advantage is many of them now actually have impregnated with silver, so it actually controls and prevents any secondary infection. And certainly case study reports and anecdotal evidence from the United States shows that these can make a considerable difference in the management of intertrigo, with some of the evidence from the States showing that you can get complete resolution of intertrigo within a few days if these products are used properly. And they're now available certainly in the UK. So to summarise then, and conclusions, takeaway messages, discussed that moisture-associated skin damage is an umbrella term for skin breakdown caused by a range of factors. What they all have in common, though, is the skin is exposed to excessive wetness. Intertrigo is one of the 4 forms of moisture-associated skin damage and is caused by moisture, typically sweat, becoming trapped in the skin folds. The skin folds then become sticky and the skin surfaces rub together, increasing friction, leading to inflammation and often secondary infection. So prevention and management requires regular assessment coupled with a good skincare regime to protect the skin from the excessive wetness, wick away that excessive moisture and treat any secondary infection. And what we do know is that the adoption of good skin fold management protocols based on a clinical consensus actually has significant benefits on patient outcome. So thank you for your time. Look forward to seeing the questions, and I have actually put the references which will be available obviously on the recording later on. Thank you.
Great, thank you, David. That was a really interesting talk and lots to think about there. And yeah, clearly it is a a condition that has had more focus on it, but clearly a lot more work still needs to be done to get that evidence base to where it needs to be. I mean, in terms of questions, I'll kick off with one from Julie, actually. So she said, can you explain how diabetes increases the risk of intertrigo?
Yeah, certainly. I'll try. Certainly type 2 diabetes, we've got the sort of mixed picture of the link with obesity and type 2 diabetes, so it's sort of chicken and egg there. Also, they tend to, due to the obesity and the diabetes and some of the changes in sympathetic nervous system physiology, they tend to sweat a little bit more. There tends to be a bit more glucose in the mix. So all put together, it's sort of a breeding ground for intertrigo developing. I don't know, hopefully that helps explain. It's probably more the diabetes, sorry, more the obesity factor that's the causal factor there.
Okay, yeah, I mean, I think the other question that we had was actually relating to the moisture wicking textiles, and just asking, is this on prescription from the GP, or would you suggest the patient purchasing that themselves?
It's coming in on some formularies. If I'm right in thinking, it is now prescribable. I would need to check that. There's certainly one that I think is now prescribable. Certainly patients can buy it themselves, but it is quite expensive.
Okay. Well, we'll do a little bit more on that as well. And yeah, when we sort of do the wrap up with the Q&As, when we send stuff out to people, we'll try and get a bit more on that as well. So David, was there a particular experience that inspired your interest in moisture related skin damage, moisture associated skin damage?
Not an experience as such. I mean, most of my research is, I'm very much a mechanistic person, so most of my research is slightly different to what you would typically think of as nursing research. So it's some of it is very lab based, and I've always been interested in physiology, and so I like to know, well, actually, why does that work, or why doesn't that work, but very much from a sort of hard science point of view, if that sort of makes sense. So it just reflects my background and my curiosity. Yeah,
and I mean, do you see in the work that intertrigo is, I mean, obviously it's mainly a problem in community and home care, but I mean, do you see it as a big problem in acute settings as well?
Where we're seeing, so certainly it can be in the obese individual. What I didn't mention, actually, we're seeing a growing risk group, and that's in what I call the post-bariatric